This short video will be covering a couple divergence of the toes that may occur. The first one that we're going to talk about for this class is hallux valgus. This is a very common divergence of the big toe. It's very plausible and reasonable that you probably know someone with the hallux valgus or a developing hallux valgus. If we remember from class the other day, remember a valgus is going to be a deformity that's going to point away from the midline of the body. So and hallux is referring to the big toe. So a hallux valgus is going to be a big toe pointing away from the midline of the body. Caused by bad foot posture, footwear, heredity, definitely heredity, some arthritis, all types of arthritis. As you develop a hallux valgus, you could develop any types of these, a callus, right, or a bunion. A lot of people call this a bunion. So you could develop a callus. Exosoci means a bone growth, which you can see here in this x-ray, or definitely a bursitis. There's a bursitis at the base of that, or at the head of the metatarsal bone, and you could definitely develop a bursitis, which could inflame there. So any of those may exist. As we get into prevention, I want to go to this slide here quickly. So these are two x-rays of the same person. This top x-ray, the person was wearing no shoes or regular fitting shoes, I assume. This second x-ray is of the same person in high-heeled shoes. So realize that when this person goes into high-heeled shoes, they are putting themselves into a hallux valgus. If those shoes are worn often enough and constantly, day after day, you could definitely see and imagine how a potential hallux valgus, a chronic or a constant hallux valgus could form because of form-fitting footwear. So coming back here to our prevention, right, we want to wear properly fitting shoes, or if you need to, wear an orthotic that takes away that stress at the metatarsal phalangeal joint. Conservative treatment, you could wear a toe pad. There's some tapes and some splints that we could do. Medication if it's just causing pain, and then obviously there's a surgery that we're going to get into. This here is just another image. This is a drastic image of a hallux valgus. Realize that some people are going to have much less of one or a developing one. This one's pretty far along, even further along than their left foot here. So let's skip ahead. So what an etiology, or what causes this hallux valgus? Obviously there could be some genetic factors, as always, right? Genetics could potentially play a factor in every injury that we're going to talk about. You could have a hypermobile metatarsal phalangeal joint, and so when you do wear those high-heeled shoes, it just pulls that toe over. We mentioned the arthritises. Remember, arthritis often is going to deform the joint. Inflammation of the joint is going to cause excessive bone growth, which could contribute to a hallux valgus. Any of these are going to possibly do that. Environmental risks. Wearing those shoes. I wanted to go over to one video. Well, let's mention this. Predisposing functional disorders. I wanted to look at this one since we just are coming off of talking about our forefoot valgus and varus and our rear foot valgus and varus. I pulled up a video, and I've heard some people mention this before. We're not in our gait unit yet, but I want you to watch this video of someone walking. This is I think it's commonly called a duck-footed walk, or their toes are going to be out as they progress forward. I want you to look at this walk and think about how it might contribute to a hallux valgus here. And actually, I'll slow this down a lot so we can see it. You can imagine as this person walks, when they supinate, pronate, and then supinate again, as they go to push off, when they push off on that big toe, they are going to create a moment arm, which is going to contribute to a hallux valgus as they push off. So coming back to our slide here, foot pronation, right, as someone duck walks and they pronate their foot in, that could definitely predispose them to developing a hallux valgus. And now imagine that they do have a hypermobile joint there. So those types of things are things we can take into account being a clinician of these chronic things that eventually will play a role. And then these other, tight heel cords, et cetera, et cetera. So moving on down, the signs are obviously going to be this degree of angle from the first toe. So usually I think we're going to have a nice 180 degree, and then we're going to deviate from that 180 degrees by a certain amount, and that's going to contribute or become our hallux valgus. Valgus angle greater than 30 degrees means severe. Here's the bunion or the inflamed bursa that are going to exist. Bone growth could potentially push that toe over, causing the hallux valgus. Let's get out of there. And we'll keep going. So management, what do we do about this? There's some nice splints, like I mentioned. We could potentially do some tape jobs. You could obviously, if you're wearing certain types of shoes that aren't comfortable, you could go back to more comfortable shoes. And then obviously there's going to be some surgeries. So depending on the amount of pain caused, they can obviously go in and surgically correct this. You can see the x-ray there of how they're going to do that. They could go in and break the bone and then place a plate in with some screws, but you see how nicely it fixes that problem there. Moving on from a hallux valgus, now we're going to do just the opposite. We're going to cover a hallux varus. So this is going to be a big toe that points towards the midline. This one is much less common than our hallux valgus. Our hallux valgus is far and away the one that you'll notice more. The varus here, it says most of the cases are congenital right there. Most of these are going to be some type of a heredity factor that is going to contribute to this hallux varus. You can see more common in populations that aren't going to wear shoes a lot. But I would say that that's the biggest thing right there is the heredity. Do you have some type of something that is going to push that big toe towards the middle? Just the opposite of our valgus, but the treatments are going to be similar, right? We have a surgery there. If we need to, we could try to be more conservative. We could try some stretching. We could try proper footwear. We could try some of those splints. It just depends on where the person is at and their treatment that they could depend on. We'll move into problems of extension of the big toe. So hallux limitus is just going to be less extension of the big toe. Hallux rigidus is going to be the toe essentially cannot extend at all. So this is a progression that someone may go through. So hallux rigidus, I'm going to move into this slide first. Hallux rigidus comes in two types. It can be an acute or a chronic scenario. So this slide here is covering the acute type of hallux rigidus. This is common in adolescents. I saw a lot of these at the high school. It's possible in class that some of you guys had a hallux rigidus due to a turf toe. Remember, hallux rigidus means that you have a tough time extending the toe without pain. So a turf toe, people have pain going into extension, and as a result of the pain, they're not going to be able to extend very far. In contrast to the acute is going to be the chronic. This is more common. What's going to happen is you're going to develop some bony formations that are going to limit extension of this proximal interphalangeal joint. You could also have scenarios where this metatarsal is more planar flexed, not allowing for motion, right, our arthrokinematic motion at the big toe. Frequently bilateral, especially if it's genetic. Primary complaint is pain at the base of the big toe. Eventually, and this is where I want to come here, eventually if you have enough of that chronic buildup, you're going to develop scenarios where you begin to ossify that joint, which is going to lead to that hallux rigidus, where really the person has essentially no movement into extension of the big toe. The joint has become so ossified together that you can't extend the big toe, which is going to create a lot of problems again in walking. Remember, I think it's, during the average gait cycle, I think you need 60 degrees of extension of the big toe. Again, this is the chronic type. It's going to happen later in life, gradually increasing pain that develops into stiffness of the big toe. And it could be precipitated by a minor injury. Maybe you have something that happens which causes a bunch of healing factors to go into that big toe, which causes some of those bone growth. Maybe the person develops a turf toe at the age of 40 that then will lead into this chronic hallux rigidus. So moving on, we've got just a couple of other we'll kind of fly through these here quickly. So the first one that we're going to cover here is a forefoot adductus. We talked about that forefoot varus and valgus. This is not going to be a varus or a valgus, but simply that the tarsal bones and the metatarsal bones are deviated medially. Just be able to recognize that there is instances where people have a forefoot adductus in contrast to that forefoot varus and valgus. Next up is a mallet toe. Some of you guys may have seen or heard of a mallet finger. A mallet toe is the exact same thing. It's a scenario where you are unable to extend the distal phalange. So this person cannot extend this phalange up. They are in a chronically flexed position. This could be to these flexion contractures. Maybe they have a problem with their extensors, or like in a mallet finger, maybe they dropped something on their big toe and so they had an avulsion fracture of that extensor digitorum profundus muscle, so they can no longer extend that big toe. Most of the time these are going to be asymptomatic unless you're in a shoe and you're developing some blisters and some sores. Moving down here, you can see here where you might develop some problems and some pain where we need to try to relieve this. A quick Google search about this showed me a nice splint here to help correct this. This is for hammer toe. There was another one that I found that was very similar to this to correct this mallet toe that's going to extend this distal interphalangeal joint. So they have some products on the market that can help do that. Let's look at the clawfoot for a second. Let's just differentiate first clawfoot from a hammer toe. Clawfoot is extension here at the metatarsal phalangeal joint and then flexion of both the phalangeal joints. The hammer toe is going to be an extension of the distal interphalangeal joint. So the clawfoot is going to be this curve, like they're creating a claw with their foot. Similar to the mallet toe, biggest problem is that you may develop some blisters, some problems here from being in ill-fitting shoes. And I think that's what I'll say about this. You can potentially have corrected footwear that puts your clawfoot, it forces your interphalangeal joints to extend. You can potentially use that. Here's that hammer toe. The hammer toe is where we have a flexion of this proximal interphalangeal joint and extension here. We might have someone in class with a hammer toe. I have a cousin with hammer toe. It's common. It happens most often here at the second toe, especially if your second toe is longer than your big toe. It just scrunches that joint up, and the way it's manifest is here at this proximal interphalangeal joint. It can be helped with proper fitting shoes. Again, you just see in the feet and in the toes how important our shoe wear is. Usually involves one toe, but it can involve two or three. Moving on down, you could develop some corns or some plantar calluses. You can kind of look through those. We have some conservative treatments. This stretching. We have some tape jobs. Again, we saw those. This was for our hammer toe, so we have some orthotics that we can use to help us, and then those properly fitting shoes again. And that's it. That ends this video covering the toe divergences that we'll need to know for class in the upcoming week.